Good afternoon, everyone. My name's Elena Janot, and I'm the Vice President of External Relations here at NCCS. And I have been asked to share a personal story with all of you about what brings me to this work. I've worked in the cancer field pretty much my whole career in varying capacities, and it stems from a really personal place for me. I lost both of my parents to cancer. My father died of esophageal cancer when he was 53, and my mother died of ovarian cancer when she was 57. And that really just inspired me to want to be involved in this work because I just felt like cancer had taken so much from my family that I had to try to turn it into a positive for my life. And if there was even one family that I could help by educating about listening to your body or regular checkups or anything that I could do to help one family, then it would be worth it. And that's sort of been my life's mission ever since. The best job I ever had was being a caregiver to my mother throughout her entire cancer journey, from beginning to end, and some of the most fond memories of my life. I learned more during that time about what it means to care for another human being, truly care about someone, and to advocate for them. And that's a gift that she gave to me that I can never truly repay her for. So every day in my work, my parents' memory is alive, and well with me. And I'm just thrilled to be able to share some of that with all of you. And I think about all the advances that have been made in cancer since the time my parents were diagnosed. And so much of that is due to people like you who have worked tirelessly to advocate, to make things better, to help that next person. And so I just feel really lucky to be with each of you here today. I hope you enjoy your time.
Wow, Elena's story is so powerful. Thank you, Elena, for sharing what motivates you to be an advocate, and thank you for all that you do for NCCS. So hello again, everyone. Yesterday, we heard from some inspiring patient advocates who set the stage for our symposium event. We're thrilled to begin our second day, which is packed with experts and thoughtful speakers who will address some of the most pressing topics in cancer care. So we're going to show you a poll right now. And while you're answering that poll, I'm going to, I have a couple of quick housekeeping reminders. So please make sure to use the chat box to ask questions of our speakers. And if you're using social media, use the hashtag CPAT20. I know some of you were tweeting yesterday during the discussions and sharing what you learned, and that's wonderful. We really appreciate that. I am not seeing the poll come up, so I'm just going to go right into our discussion with our distinguished panelists. We have a group of renowned oncologists here today to talk to us about the future of cancer care. So over the past decade, cancer treatment has developed at a rapid pace. As researchers better understand the biology of cancer, new therapies and advances in treatment are booming. From targeted therapies to immunology, medical breakthroughs have transformed cancer care. Yet disparities in outcomes persist, and not everyone benefits from these advances in treatment. In today's opening session, we get to hear from leading experts who are going to share with us what they anticipate for the future of cancer care as we launch into this new decade. We can't talk about the future without addressing COVID-19, and there's much to discuss about the impact of COVID-19 on cancer care, but we also want to look beyond COVID at other important trends in cancer care. I'm thrilled to welcome Dr. Otis Brawley from Johns Hopkins University in Baltimore, Dr. María López from the Sidney Kimmel Cancer Center in Philadelphia, Dr. Raghavan from the Levine Cancer Institute in Charlotte, and Dr. Deborah Schrag from the Dana-Farber Cancer Institute in Boston. So in our rehearsal this morning, they had such a great conversation among themselves. I could really just turn it over to you all and not moderate, but I'm going to keep the moderator's prerogative and ask you a few questions. And I wanted to start by giving each of you a chance to respond to the opening question of how do you see cancer care evolving in the next 5 to 10 years? So we'll go in alphabetical order. So I'll start with you, Dr. Brawley.
Thank you. And thank you for inviting me for this. We've made a lot of progress in cancer, some of it in cancer prevention, some of it in screening and diagnosis, and then a great deal in cancer treatment. I think we're going to continue with that progress. However, I'm a little bit concerned things like the coronavirus infection this year is going to set us back. There's some data that suggests that mortality from cancer may go up 2 or 3% in certain cancers in the early 2020s because of coronavirus, and then we're going to have some effects well to 2029. Now, I see a lot of progress, but I also see still a great deal of problems. Much of my work in epidemiology and health outcomes research has actually shown that we've had much greater declines in cancer mortality in the northeast of the United States, for example, versus the southeast of the United States. So I'm seeing disparities that are going to continue. I'm actually predicting that many of the disparities are going to become much more socioeconomic, and we're going to be talking about the differences in breast cancer outcomes in white women in Mississippi versus white women in Massachusetts, more so. In the past, when we talk about disparities, we talked about race. But I see more disparities, but I see more progress, and I'm generally hopeful.
Great. How about you, Dr. Lopez?
Thank you. Thanks again for the invitation, Shelley and team. It's a great pleasure to be here with you and certainly with advocates, because you have taught me so much of taking care of patients. So thank you. Tremendous progress, yes. Certainly the broad use of telemedicine has had a great impact, and we'll be able to carry those lessons forward. I think people estimate that the growth in the last few months has been the equivalent of what we anticipated to see in the next 75 years. So tremendous impact, a lot of lessons, and really to know what are the lessons that we can carry forward. So in a way, I think of it as just another step in precision medicine. There have been changes in how we take care of people. And we may now know that, so these are alternative approaches that are just as effective. So we've had this opportunity to this natural experiment to really see how things can evolve better in the future in telemedicine, in patient care. And as Otis mentioned, this has just taken off any Band-Aid we might have had on healthcare disparities. And that it's not just race, ethnicity, gender, which we've all been working on. It's really everything. And the impact of the economy, the socioeconomic impact that we'll be seeing in the next few months, in the next couple of years, that will also really, it forces us to address equity. It forces us to address access to care. And that's, although maybe difficult for us, it's a tremendous opportunity to hopefully get it right.
Thank you. Dr. Raghavan?
I think you're going to see a lot of similarity in what each of us says. Like the other two, I'm delighted to be here with you again and with the NCCS. I think the next 5 years will be a time of great progress. We're seeing huge impact from translational research, particularly with the new immuno-oncology drugs that are changing the way we think about cancer. Careful use of CAR T treatment in specific malignancies is going to be a game changer. And instead of looking at p-values and statistical quirks, we'll be looking at major differences in outcome. I always like to quote the very famous Otis Brawley in his presence. And Otis once said some long time ago, something that he actually wrote it, that if every patient with cancer in the USA could get the survival of a college-educated white male, we would reduce the death rate from cancer by more than 50%. It's roughly a paraphrase, but it's the general intent of what he said. And it's true. And so as Anna Maria and Otis both implied, the Black Lives Matter initiative at the present time, which has always been a constantly important thought, but has taken prominence because of selected areas of police malfeasance, that will impact the way we think about the underprivileged in healthcare. Now, I personally think it'll matter tremendously what happens in the federal elections in November. And I see a real division in health philosophy between the two parties. One that seems to be more focused on addressing the health needs of minority populations. And I think evidence in support of that is the extensive data that supports that death rates from cancer are lower in states that have expanded the ACA. And then another side that's focused more on business and the things that go with business. I think the same division is evident in our current approach to the COVID pandemic. And as a physician who is on the front lines in a big system, this matters tremendously. So I think we will no longer be able to pretend that it doesn't matter that disparities exist. We will have to address them as part of taking healthcare forward and ensuring that the underserved populations have the benefits of all the progress we've made in translational research.
Great, thank you, Dr. Raghavan. And Dr. Schrag.
Yeah, so I couldn't agree more. And I echo the comments of my esteemed colleagues. And again, thank you to you, Shelley, for the opportunity to attend today's event. Another wise saying from Dr. Brawley has to do with the fact that he likes to put it, and again, I'm paraphrasing, your destiny should not have to be your zip code. And we just have tremendous regional variation. We live in one United States, but there are many, many different areas of the country where healthcare and cancer care, the experience for patients is very, very, very different. And that is unconscionable to all Americans. And there's a lot that we need to do so that people's zip codes do not become their destiny, as Otis likes to put it. Race is just one facet. So I think I'm an optimist over the long term. I'm a tremendous optimist. I think what's painful is that sometimes out of adversity comes growth and change. And we're having a moment right now where there's 3 crises at once. And I would say the acute crisis, which is new, is the COVID-19 pandemic. The crisis of the past few weeks with what we're seeing, really police brutality and deaths of Black Americans, is a more long-standing chronic crisis that has erupted in a very vile and flagrant way over the past few weeks, but it is a chronic, not a new problem. And the third crisis, of course, is the fact, and related to both of those factors, is the fact that so many people are losing their jobs and have financial insecurity, which is, again, has an acute component related to the pandemic and a chronic component as well. As I think Derek really articulated, these 3 features mean that we cannot ignore how they combine to impact the entire spectrum of cancer care, from access to preventative services, timely diagnosis, to state-of-the-art cancer treatment, including the ability to leverage new technologies like immunotherapy and CAR T-cell. I think we are not going back to the way we used to do business. And we've had tremendous change. It will stick, but we need to figure out how to make it stick and last so that it best serves the needs of patients. And to do that, we need partnership, Shelley, from organizations like this one. We really need to bring the patient voice into the conversation. So I would say to get there, we need your participation. Those of you attending an event like this, we need to actually do less talking and more listening. So what do I think is going to be a feature? I think we're going to see more telehealth. I think we're going to see more cancer care happening at home, more patient engagement in leading and directing their own care, making cancer care work for people whose families take care of other families, work even part-time jobs, or people who live in rural and more remote parts of the country. We need to do a much better job of making cancer care work for everyone. I think we can do that with technology, with legislation, with electing enlightened leaders to public office. So participation in electoral campaigns is critical to this, and advocacy is absolutely critical to this. So again, I think in the long run, we need to use the crisis as a catalyst for change, but I think we can do that.
Okay, thank you. I think we could probably have an hour on about 4 different topics that you all touched on in your opening comments, but I want to stick with the health equity to start because I loved what you said, Dr. Lopez, that we've ripped the Band-Aid off of health disparities. And I think, it's something we've known for a long time. We talk a lot about. We know that, as you mentioned, Dr. Raghavan, that the Affordable Care Act has helped reduce some of those disparities. What are the other policies that we need to be advocating for to help reduce those disparities? Because I know Dr. Brawley has talked eloquently about it's not just a race issue, although there are racial disparities in outcomes as well. But when you say that if everyone had the care of college-educated Americans, then the death rate would be reduced. So besides strengthening or protecting the Affordable Care Act and access to insurance through Medicaid, what are other things that we need to be doing?
Well, I think that I once addressed the President's Cancer Panel on this topic, and I made the point that the biggest impediment to progress is analysis paralysis. And I still think that's a big issue. People love to sit back and formulate the perfect plan, almost as if they're afraid to make a mistake. And so I think the idea of doing things well is to say, let's get on with it and modify as we get going. Shelley, you're familiar with a program that we initiated here with absolutely no major supporting data, which was to develop a mobile lung cancer low-dose screening unit. We built the first mobile unit. We sent it out into the boonies, and basically we did it without a certificate of need. We're a certificate of need state. So what that means is, by definition, we created a unit that legally cannot bill. Therefore, it can only be used for underserved populations. We've screened more than 1,000 heavy smokers. We've published the data. We found a stack of people with lung cancer, some incidental cancers, heart disease, and we've treated those. And my point is, it may not be the right way to do it, but it's a start. Instead of sitting back and designing it and thinking about it and considering a trial and having meetings, we actually got the thing going within a year of inception. And Otis actually has come and seen it in operation, and it works. It's probably not perfect, but during that period, we've screened more than 1,000 people. So I think having the interest and then executing rather than planning is going to be one of the things that will change things. This is in the crucible at the moment. It is a focus of attention of the medical profession and of society. So it's an amazing opportunity to do this. As Deb said, quoting Otis, you can't let your zip code interfere with your ability to get great care. And so the concept of breaking down the megaliths into component parts, so that instead of cancer centers existing only in part of a big city, you dissect them and put outreach satellite sites that will allow patients to participate in trials, get the benefits of genetic counseling and all the supportive facilities of a major center. So you cut and slice the entity and bring it to the people. That's going to make a big difference.
Yeah, the original comment was noting that poor people tend to live in certain areas and wealthy people in other areas. in the United States, your zip code is more important than your genetic code when it comes to cancer outcomes and many health outcomes. Starting with that, I would say that we really need to focus broadly on prevention. There are lots of people in the United States who get cancer because of smoking still. Second leading cause of cancer in the United States is an energy imbalance. It's the combination of obesity, too many calories, and not enough exercise. About 30% of all cancers are due to that. A focused effort on smoking and energy balance can prevent a large number of cancers. Then we need to focus on appropriate screening and early detection, and there is such a thing as inappropriate screening. And then, of course, for people who have disease, getting them access to good care and the ability to use that care. And for that, we're going to need certain things like navigation programs to help people who are less familiar with the medical system to actually get through the medical system and get good access to that care. You know, Dr. Schrag does a lot of a lot of studies of how healthcare is practiced in the United States. And many of those studies show that a substantial number of people with cancer get what the lawyers tell me I have to say is less than adequate care.
So I think education is really important. And the thing is that we know that what we know and what we do are not always the exact same thing. So really meaningful, transformative education. And this is, I think, as much for us as it is for our patients, because in that process of working with populations, it is transformative for the health system and for us. But that can really help people take charge of these different aspects. So, you know, a lot of times people feel that, what does it matter? You know, maybe everybody in their family died from breast cancer or from another illness, from diabetes. And they think, well, I'm not going to live long enough for this to matter. So to really inspire people to participate in their healthcare, to really feel that they have the ability to make some of these changes, and that these changes can make a difference to them, to their lives, and to their families. And part of doing that is really working with the community, is really working with community health workers, with promotoras, to really, you know, work together, make this meaningful, and make this change. Tremendous opportunity, I think, in that, to be able to work with our patients.
Thank you. So I want to talk a little bit about how COVID has impacted oncology practice. And I know, Dr. Schrag, you and some colleagues wrote a piece that was published in April about how oncology practice is changing during the COVID-19 pandemic. And I'm wondering if you could tell us a little bit about what you all found and you talked also about how this is sort of a catalyst for transforming how we deliver cancer care. And I'd love if you could talk a little bit more about that. Dr. Schrag, did you hear the question?
Sorry, I apologize. I didn't hear that. I apologize. I didn't hear that it was to me. I'm so sorry. My connection was having problems. COVID-19 is having a tremendous impact in our healthcare system. And I'm hearing the same thing from investigators and cancer physicians, nurses around the country. I will say that it's not 100% bad. So it's all the ill effects are obvious: the physical distance, the isolation, the not being able to put your arms around your patients, the lack of physical touch. Those things have been often mentioned, and they're absolutely true. But I just will say that there's also a certain intimacy that I've heard about and I've experienced I'm inside patients' homes. I have patients who I've known for years, but I've never seen the inside of their house. I've learned about their hobbies. I've seen their, the quilts that they make, the blankets that are around their knees, what their living rooms look like, what they're eating. It's also very intimate. Unfortunately, during face-to-face encounters, we spend a lot of time staring at the monitor that has the electronic health record. But now on these Zoom telehealth visits, I'm staring into my patient's eyes. There is a certain intimacy. I think we need lessons on how to be good physicians and get the best out of those remote encounters, but they actually can be strangely intimate once you've gotten past the technological glitches and challenges that I think we've all experienced. I think the anxiety is tremendous. Anxiety is something that's known to every cancer patient, but another silver lining of COVID-19 is that everyone is anxious. And I've had cancer patients tell me, everyone's anxious. Now they understand my reality that I live in fear of my cancer X fill in the blank coming back every single day. And other people are getting a taste of my world and they're strangely more sympathetic than they used to be. And that empathy is healing to me. So I think the silver lining of this awfulness is I think people are tapping into, I guess I would call it the innate human goodness and empathy. And I think we need to really figure out how to grab onto that and just that empathy and kindness, why we all went into a helping profession. That's what patients want from their providers at the end of the day. And that's why clinicians went into clinical medicine. And I think we are in this pandemic connecting to that. And I wish we could have on that.
I think we're losing her audio. I'm wondering, while we hope to get her back, could we show the poll results? Because I think they, I would love for our panelists to be able to see them. Apparently, I didn't see that the poll had gone out to you all when you were responding to it, but we asked about during the COVID pandemic, and we asked about some of the effects of your cancer care, and about 30% said that you had a telehealth visit with your cancer care team, and about 36% said you delayed a cancer-related scan or screening test. So I've mentioned yesterday that NCCS is doing a project to bring patient perspectives to telehealth, and we're also looking to get input from providers. So I love hearing some of the comments you made, Dr. Schrag, about the kind of the silver lining of the telehealth visits, where you can actually see a different side of your patient than you might have otherwise seen before and have different kinds of interactions. So we've done some focus groups to bring patient perspectives to what they're experiencing with telehealth and what we need to do to make sure those are effective visits. And we're looking forward to sharing the results of those soon. But I also want to, so I'd love to hear from the others of you about both telehealth, other changes in cancer care, and also we can talk a little bit more about how some of the delays in scans or tests may impact the outcomes. You mentioned, Dr. Brawley, at the beginning, and the data that or the modeling that was reported that show increase in cancer-related deaths. And if you could talk a little bit more about where that's coming from. So I kind of asked 3 questions at once, so you can take it from there.
Sure, I'll take the lead and go backwards, perhaps. The National Cancer Institute has a modeling program for populations and for cancer care and cancer trends in that population. It's called the CISNET program. And the CISNET program modeling for coronavirus has shown that the delays in treatment and problems with treatment due to social distancing, shutting things down, are actually going to lead to some increase in mortality that will extend over the next 10 years, be at its highest 2 to 3% higher mortality in 2021 than 2023. Interestingly, it's not delays in screening that are causing this. It's delays in treatment, and then also some treatments that end up being inappropriate because of some of the social distancing and other things. Now, many of our patients are still having difficulties and will have difficulties over the next several months. Many doctors' offices are seeing 50% of the patients that they would normally see. Some have added on extra hours to try to take up that number, but you still, there's some people who are going to get less than optimal cancer care because of our new social situation. The thing that every patient needs to try to do is to optimize their care. And one of my concerns is the people who are going to end up getting the greatest disadvantages to this new system are poor folks. It's not necessarily Black, it's not necessarily Hispanic, it's the socioeconomically deprived. I can even tell you that from some of our work, it's going to be more people in the southern United States, the old South versus the West or the Northeast.
Great. Dr. Raghavan or Dr. Lopez, do you want to chime in on any of the questions, the three questions I asked at once about changes in cancer care, telehealth, and kind of what the impact on cancer will be going forward, cancer outcomes?
You go first, Anna Maria.
One thing that's been interesting to see in the telemedicine, there's the regular visits that could be done, but there's also the opportunity to follow people over a longer term at the home and to facilitate some of our services to be done at home. So this could be more home health care services, but it could also be infusion of therapies. And some of this could be done in collaboration so that there could be maybe post-operative care where the patient may have stayed in the hospital, but with the concern of having people in the hospital, where now this sort of care could be done at the home, which really lends tremendous opportunities for the patient, for the caregiver, for the family to really be together and work with the healthcare team. But it also brings up barriers, and some of the barriers, things that we've talked about a little bit is, so it's so interesting because there are incentives, there are things that we think, well, why is it that way? Because it's structured and incentivized that way. And so what some of the barriers for some of these home health applications is really that's how it's reimbursed. It's reimbursed better if it's in the hospital setting. It's not reimbursed in the home setting. And I can tell you, in trying to work with many, many patients in the last few months, where it would be very reasonable for even something as simple as blood work to be at home, that the barrier is not the health system, but is the insurance system. So uncovering other barriers, other possibilities for solutions.
Mm-hmm.
One of the things that we've learned that was fascinating as we, like Anna Maria and Deb and Otis, have moved more to virtual consultation. About 40% of what we're doing is virtual now. And we've actually discovered that one subset of our cancer community really loves this vehicle, and it's the group who are undergoing supportive oncology interactions. So the cancer integrative medicine group, the pain management team, the psycho-oncology team, and so on, the patients really have been very positive about this. And while I think everyone would acknowledge and agree with Deb's point that it is tough not being able to hug a patient or put your hand on his or her knee at times of stress, the fact is that they don't have to leave home. They're more relaxed. They have a lot less other stuff going on. Many of the underserved actually benefit because they don't have to deal with transportation issues. Our system is a safety net, and we've done a nice job in making sure that transportation is available, but it's still an issue. And so one of the things that I think will not change is there will be a population of patients who will say, whenever possible, can I have virtual? I think we need to be careful because, as always happens in North America, when something is new, it's automatically wonderful and isn't always assessed critically. And so we need to be very mindful of the fact that the classical, conventional physical examination is not part of virtual consultation. And the young Turks will say, yeah, well, you can get a mammogram and you can get this test and that test. But at the end of the day, every one of us on the line can give you innumerable anecdotes about the time that a scan was negative or a mammogram was negative and physical exam revealed a lump somewhere. So we don't yet know how completely safe virtual consultation is. I think at the moment, it's very desirable for patients because they're afraid. They're, as was said, they're afraid of coronavirus. They are afraid that they have cancer and maybe altered immunity, plus they have a risk of getting this virus randomly. One of the things that we've done is to emphasize what we've done and educate our patients so that they have a higher level of confidence that they'll be safe. So every one of our staff wears a mask. Every patient wears a mask. We no longer allow visitors unless there is a specific reason for the visitor to be there to provide specific emotional support for the patients. We've changed our waiting rooms so that they have seats that are less close together, and we arrange our booking schedule so that the waiting rooms are empty. And explaining that to patients, those who do need to come here physically, I think gives them a sense of confidence. One has to be careful not to give false reassurance. The idea that you can create a safe environment is factitious. There is risk, there will be risk. I think every one of us would accept life has changed. I think back to the Shattuck lecture that Gates gave about 3 or 4 years ago about the risks of a pandemic. And it was a fabulous lecture, but it was largely ignored. That has come to pass. And this is not necessarily the last pandemic we will see. We now have modern experience with how to deal with them. And in the cancer community, how to address the conflicting pressures of COVID versus treatment and so on. But as Otis said a few moments ago, there will be patients who will be dying because they or their doctors have been afraid to treat. And so we've written pretty careful guidelines for our own use that indicate that balance. And we've actually codified some of those in a paper in Journal of Oncology Practice. So I think as we gain knowledge and we share knowledge, one of the things that's fantastic is the amount of material that's really thoughtful and well crafted that has been rushed to publication without necessarily all the barriers that editors provide to get the information out there. And the journals have opened it up with open access. So there is a new tradition of information sharing that I haven't seen in my career. And that'll perhaps go away, but at the moment, it allows us to feel that we're all in this together, both doctors and nurses and patients working as a unit entity.
Great. Well, thank you all. And I just want to note that Dr. Schrag had to leave us a little bit early because she's in clinic today. And so she knew she wasn't going to be able to stay the whole time. So we thank her for being here for the amount of time she could be. And I also want to mention that we do have a session next week, a breakout session where we're going to share our initial initial findings from our focus groups with patients about their use of telehealth and what recommendations they have to make it more effective. We did hear a lot of patients really liking it. I think, there's the technology barriers that some face, but also, as you mentioned, Dr. Raghavan, avoiding having to take off from work, having to deal with transportation to get to your appointments for people that, have to take time off of work. It makes a huge difference to be able to have those meetings with at home or in a setting where they don't have to take time off from work. So, but we also have some great recommendations from them on what needs to be done to improve and make those meetings more effective. So we'll be sharing the beginnings of our findings from that next week at a breakout session. I'd love to turn now to talking about financial toxicity, which we know is a huge issue for people with cancer during and well after their treatment, and years and years after their treatment. I know this that you all have something to say about this, but Dr. Raghavan, you've mentioned that you all have a fiscal toxicity tumor board. Can you tell us a little bit more about that?
Sure. So virtually all cancer centers have some type of multidisciplinary tumor conference. They're usually focused on a specific tumor type. So breast cancer will have medical oncologists, radiation oncologists, surgeons, etc., talking about each case and trying to ensure that there is a sensible consensus that isn't just driven by the treatment preferences of the one clinician who's working there. I got to thinking about this and the issue that, the cost of drugs is going up, people are losing insurance and so on. And so about a year ago, we started up a multidisciplinary tumor conference that was about financial toxicity. We have a tool that every patient fills in electronically on arrival that asks some basic questions about how they're doing and includes a question: are you struggling financially as a result of your cancer care or otherwise? So we've actually had a kind of a safety net monitor for that aspect. But now we've actually got our nurses specifically asking more detailed questions. And then the tumor board has both the people in the billing office, people who are financial counselors, the chairs of the departments, people who are interested in this as a research space. We have 40 navigators in the system, so they have representatives there. So pretty much everybody with skin in the game, patient representatives as well, who've signed HIPAA compliant forms. And so this meets every month. We discuss paradigm cases, so examples of where something has happened that is a problem. And then we get the relevant social organ or clinical organ to address it, and then build and modify our standard operating procedures to avoid it happening again where possible. We've reached out on one issue that had to do with biomarkers and the lack of reimbursement for them. We reached out to ASCO to ask if it was on their political agenda. We've called insurance companies. We've addressed our own billing office if we see a procedure that is inadvertently causing harm. And again, it's another example. Rather than having analysis paralysis and making it perfect, we got started learning as we go. We've got our first publication of what we've been doing in the hopper at the moment. And hopefully that will get people thinking about the idea and saying, yeah, this is a big deal. It's every bit as important as whether you have nausea that's poorly controlled or pain that's poorly controlled. And so this will become another basically vital sign of cancer care and of general medical care.
Derek, you have what I'll call a very high functioning cancer center. It's a cancer center that's able to do a lot of very good things and resource rich. Unfortunately, there's certain cancer centers in the country that can't afford to offer lung cancer screening because taking money and resources to build a lung cancer screening program will require robbing resources away from other programs that actually have the potential of saving more lives. It's just unfortunate that, this is the richest country in the world, the most expensive healthcare system in the world, but there are some safety net hospitals especially that cannot offer all the services that we'd like to see them offer.
Yeah, I think that's true, Otis. But again, we're a safety net hospital and it's a question of prioritization. And it comes back to your comment about zip codes and having outcomes. I think you're right. Cancer research is crucially important, but we do have a tendency to focus on getting a new treatment that might improve survival by maybe 3-4 months in 4% of the population and expending vast sums on that, always hoping to find the Holy Grail. Now, with PD-1, PD-L1 immuno-oncology drugs, it's paid off. You and I are two old campaigners who have been around a long time. If you think of all the money that has been spent on stuff that doesn't actually help a lot of people, you could argue that it's worth making a carve out early where a set proportion of even an under-budgeted cancer center is focused on things that will make big differences in big parts of the underserved community. And you have more live bodies at the end as a result.
Yes.
Dr. Lopez, do you want to add anything on financial toxicity? Is there anything that you all are doing at your institution, or what are you seeing with your patients? Oh, you're muted.
Sorry.
There we go.
First, I love the idea of a financial toxicity tumor board. So I may borrow it. I think it's good. Thank you. You know, one of the things that we've done, and in thinking about the whole telemedicine dissemination, and of course, you know, you can imagine that a big barrier to telemedicine is the lack of technology. And not everybody has an iPad or an iPhone or a laptop to be able to join. And in just, you know, beginning to do this scheduling, what seemed obvious was confronted in reality. And something that our group was able to do was really put together a telehealth task force. And this group identified all the different barriers. And the first one, of course, was lack of technology. And then if that was identified, to try to work with the patient to get them access. So whether it was really, we're going to buy you an Android phone, we're going to buy you a tablet, and you're going to use this to be able to stay connected to your healthcare team. Then actively working with people, okay, you've got the technology, now let's help you get there. You know, let's get you onto the platform we use is the MyChart platform. You know, so work with you, which can be an investment of time. But then just because you're set up on MyChart doesn't mean you can get to the telemedicine appointment. So let's get you to, you know, navigate to that, and then let's set up a test visit. So to really be able to walk people through from access at its very concrete, the technology, to really, let's educate you, let's work with you, let's help you to understand the pieces, and then you can be self-sufficient in following this through. So I think that's another way to really stepwise deal with address some of these barriers.
You know, Shelley, it bears to mention what Derek said earlier. We're now more than 10 years into the Affordable Care Act, and we've got very clear signs that states that fully implemented the Affordable Care Act with Medicaid expansion have lower cancer death rates, and even in other diseases have signs that we're going to have even lower cancer death rates because populations in those states are able to better have access to healthcare compared to the states that have not expanded Medicaid.
Yep. That's a very good point. Okay, so I know we've kind of gone back and forth talking about COVID related topics, but it's hard not to talk about it when it's something that we're all facing. And we talked a little bit about this morning on our prep call, but can you talk about protesting and social justice in a time of COVID? Because obviously, you know, people have made the decision that it's important enough to take the risks that they're taking by participating in the peaceful protests that they have been participating in that continue even, you know, weeks later. So I know I've talked with cancer survivors who feel like they would really like to be out there, but don't feel comfortable. But, you know, can you talk about and we also talked a little bit about, you know, differences in how some states have approached reopening the country, and what do we, let's talk about social justice in a time of a pandemic and the risks that people are taking, I guess, by going out there.
You ask a couple of different questions. I'll start out by saying that there are several states that started opening up very early and opened up very quickly. For example, Georgia and Texas. And we're starting to see increasing numbers of people hospitalized. The politicians will say that coronavirus cases are going up because there's more testing. I'm going to look at hospitalizations and I'm going to look at deaths because those are not affected by testing. In Georgia and Texas, a couple of other states that opened up very early, we're starting to see increasing numbers of people hospitalized. I think we're going to, in the next several weeks, see increasing numbers of deaths because they opened up in a not very wise fashion. We're also going to see increasing numbers of whites and rural Americans with the coronavirus. The early wave were minorities who lived in big cities like New York, Detroit, Chicago, New Orleans. The next wave is going to be lower middle class primarily, but white Americans, especially people in rural America. Now, you also mentioned the question of the protests that have occurred. We've yet to see a rise in rates because of the protests. Those may come over the next week to 2 weeks, hopefully not. Those protests are outside and they involve, if they involve people who stayed distant, who still wore masks, I'm hoping we're going to have less transmission. I'm not one to say that one should not protest. I will say I am concerned about cancer patients under active treatment and people with other immune deficiency conditions going out and protesting or doing anything that puts them at increased risk.
You know, I think a really important point is it's a little bit like the old concept of Russian roulette. You know, if you have a 6-shooter and you have 5 bullets, it's not safe. But if you have a 6-shooter with 1 bullet, it's still not safe. And so the reality of the situation is if you wear a mask to a demonstration, that doesn't mean you're safe. I agree with Otis. You know, each person needs to make a decision of conscience, but they need to make the decision realistically. And if you watch some of the demonstrations, you see people taking their masks off to greet each other. You see them with masks sitting under their noses. You see them with masks under the chin. You'll see them marching arm in arm. They do things that in the context of COVID are simply unsafe and unwise. You can certainly go to a demonstration and show support for the communities that have needed it for such a long time. So I, like Otis, think it's a time of choice, and it's certainly an incredibly important area in which to make your feelings felt. But say if hypothetically you decide you want to be at a protest, you don't necessarily have to be front and center surrounded by 1,000 close bodies. You can be standing with a placard at the periphery and getting some airspace that is likely to be less infested by coronavirus. People talk about the N95 mask about being completely safe. Not true. It reduces the risk. Surgical masks reduce the risk. Cloth masks maybe reduce the risk. We keep telling each other these anecdotes based on very little hard evidence. And so I think the reality is this is a time of cataclysmic change, way overdue. We should be exercising our rights to protest. I, like what Deborah Schrag said a little while ago, think that the voting box is going to be the place to do it. And I plan to vote, but I'll probably do it by mail rather than showing up at a polling booth. I think using common sense and accepting that you can reduce risk but not to zero, and then you exercise your right to protest in a rational and thoughtful way, allows you to be socially appropriate but also to protect your health.
I think it's a really important point what you said about there really is not a safe space. You know, we can reduce risk. We can reduce risk by washing our hands frequently or using hand sanitizer, by using a mask, by maintaining distance, but there's not 100% safety. And it really means doing all of those measures all of the time. Certainly very powerful that many people are aware of the risk and still choose to go out because they feel so compelled by the injustices that are out there. So it is a a time of a lot of change, and we're there, you know, to support people and to educate people and to try to empower them with, you know, what can keep you as safe as possible.
Well, thank you very much, all of you, for a wonderful conversation. We really appreciate you taking time out of your busy schedules and your busy clinic days to be with us here today. We appreciate each of you for your time and your thoughtfulness. And now we have a break until 1:30 when our next round of breakout sessions will begin. We're not coming back for a closing session today, and we do have an upgrade to the technology today, so you should see buttons on your screen that allow you to navigate directly to a breakout session. So the breakouts will begin at 1:30. If you have any issues with the buttons, you can always go back to the email that you received, that you should have received this morning that has links to the breakout sessions. So thank you again, everyone, for joining us, and to our wonderful panelists, and we will see you all back here at 1:30.
Thank you.
Thank you. Thank you. Bye.